So these are my affiliations. So on the bottom right, I work at St Andrew's Hospital in Brisbane. My own academic professorship is with the Queensland Brain Institute at the University of Queensland, and our centres that we conduct our research and education through is the APCN, the Asia Pacific Centre for Neuromodulation. So just to set the context of movement disorders, which is going to talk about neuromodulation for. So particularly deep brain stimulation. So that's an invasive neuromodulation. There's non-invasive brain neuromodulation techniques. People may have heard of transcranial magnetic or electrical stimulation. Probably that's not really made it into mainstream. It's not very evidence-based at the moment, and for the sort of pointy end of these problems, we really have to do invasive therapy at the moment, and deep brain stimulation is what we do. So maybe in the years to come, the things will be less invasive, but not quite now. So the conditions, the movement disorders that deep brain stimulation, or DBS, has been shown to be efficacious and efficient at Parkinson's disease. Essential, everyone has Parkinson's, I guess. Essential tremor, which is almost as common as Parkinson's disease. You may have seen, you might know people that sort of, they just have a symmetrical bilateral shake of their hands, or sometimes their head nods. For the vast majority of these people, it's sort of like a little quirk to their activities and doesn't really interact or interfere with their quality of life. But for a certain number of people, it becomes very disabling to the point where they can't use their hands, they can't function, they can't feed themselves or dress themselves. And there's another less common condition called dystonia, which is where the brain's electrical impulses to the muscles become scrambled and the muscles work in irregular ways, and that can cause spasms or writhing movements. And although uncommon, that can be a very terrible condition. And for essential tremor and dystonia, there's not really very good treatment. So if it becomes bad enough, neuromodulation is really all we can offer. So for Parkinson's disease, we all often think of it as an older person's condition, but it's important to remember that 10% of people are less than 40 years of age at diagnosis, and 20% are less than 50 years. So, and David spoke to this a little bit. So when do we think of something like DBS for Parkinson's disease? Well, this, without trying to get too complicated, just shows that when symptoms first begin, the light blue line is when a person's having a good quality of life, and then you add some medication and you can keep people in that light blue part of the graph for a long time. But eventually, over time, and it varies, some people do, as David mentioned, have a more aggressive time course of their disease. Some other people it's a bit slower, but eventually the tablets stop working effectively. They wear off too soon, or they wear off unpredictably, and then sometimes the tablets cause these excessive movements, these dyskinesias that David talked about. So as time goes on, having a good quality of life in that light blue area gets less and less and less. And not only does it get less in time, but the unpredictability of it becomes a factor. So it becomes really limiting in what people can do. And really at the moment I'm talking about the motor symptoms too. It's important to remember, as David talked about, the motor symptoms are the freezing and slowness of movement and the tremor. But there are many other non-motor symptoms for Parkinson's disease. And our neuromodulation is primarily to help the motor symptoms. So when people start to get into that poor quality of life where the medication's just not really holding their symptoms, then we have in Australia what we call 3 types of device-assisted or advanced therapies for Parkinson's disease. And 2 of them are infusions. One is through the skin and one is through a feeding tube into the bowel. There are 2 ways of giving the medication, sort of not via tablets. And then there's neuromodulation or deep brain stimulation. So different people are suitable for different types of those advanced therapies, and that's something that the person who's reached that point in their disease journey sort of discusses with their movement disorder neurologist. But particularly where I come from up in Queensland, if you have any of these infusions going, which are sort of 24 hours, it sort of gets hot, you can't go in the water and cool off and sort of hot and sweaty and things. So have something that's completely internal is sometimes a preferred option. So just to give a little background of the theory of DBS in 3 easy sentences. So we think of the brain having electrical circuits and networks. So when I was a sort of a medical student and a young doctor, all the focus was on the brain cell, the neuron, and we're all trying to work out how the neurons worked and how we could make them work better. But we've got a more sophisticated knowledge of the brain now, and it's these neurons working in cohesion in circuits and networks. And for conditions that DBS can help, the circuits are impaired, they're not working properly, but they're not physically destroyed, so DBS can't help restore sort of lost areas of the brain, but when the brain areas are still structurally intact, but they're just not working very well. So with Parkinson's disease, for example, the medication dopamine is not there, and that affects the motor circuits, so the circuits are still there, but without the dopamine, they're just not working very well. So DBS restores the way the circuits work, and don't use too many medical terms, but we don't really know how it works exactly. But often with Parkinson's disease, for example, the activity of the brain is like, when you're moving, it likes to be a bit discoordinated. It looks like it's sort of a bunch of popcorn going off, but when it flips into being very orderly and the brain cells are very synchronized with each other, that seems to bring an abnormal movement state. And so having DBS sort of disrupts the electricity that we deliver, disrupts that abnormal synchronized brain patterns. So why it's called deep stimulation is because we do go to the deeper parts of the brain. So the surface of the brain, or the cortex of the brain, there has been trial for neuromodulation, but the results have never been really very good. So what we need is we need leads with electrical contacts in the right part of the brain. We need what we call a pulse generator, the implanted pulse generator, the IPG, or the battery. And then we need a programmer. So the programmer is the device, and David showed sort of the device that gets used, but also need the human to program the device. And this just shows sort of the parts of the brain that we can attack, so to speak, to place our leads. So that's why it's called deep. It's sort of not on the surface. And for people with a little bit of a medical background, these structures that are coloured are called the basal ganglia. So the basal ganglia are relay stations on the electrical circuits to do with movement. So when part of your brain tells your arm that your brain wants your arm to move, well, the thought to make the arm move, it passes down through those basal ganglia structures, and that's where the message gets processed, and then it gets fed back up to the movement part of the cerebral cortex to make the movements smooth. So when there's some disturbance of that processing the basal ganglia, that's where you get these disturbances such as David had. So that's just sort of a little real life picture just showing that where sort of on the left you can see the sort of the lead going in from the surface of the skull down into the target in the basal ganglia. The picture to its right shows that leads have varying number of contacts, so that gives the person programming some options. You can sort of program different contacts, or you can program them sort of part of each contact. And these days there's sort of even directional leads, so this wasn't available when David had his procedure. And some of the side effects David talked about in the sort of something that's brand new is you can steer the current to different parts of next to where they've been placed. So traditionally the current was in just a sphere around the contact. Now you can shape it, so if someone's having a side effect like speech, for example, you might be able to steer the current away from that part of the brain that's being affected. And so the slide on the right, or the picture on the far right at the top, that's just showing how we've passed an MRI scan showing how we've passed the lead down into the part of the brain we want to target. This is just to show that there's, again, schematically these circuits in the brain, so we try and have an understanding of how different parts of the brain communicate with others. And it's sort of like there are nodes, there are relay nodes along the circuits, and that gives us different sort of nodes or different targets we can put leads in depending on what the particular problem is we're trying to help. So what have we learned so far? This is just a photo of our operating room. So I'm just sort of sitting behind the patient with the mask on, and the person holding the patient's hands, that's my neurology colleague, Professor Silburn. So we're just sort of doing some test electricity, and Professor Silburn's just sort of feeling for the effect of electricity on the person's stiffness. So we know pretty much sure, and we heard earlier, the people over here earlier this morning hearing about these things in medicine called randomised controlled trials, where you take a therapy and you sort of apply it to the previous best treatment without that therapy, and the patients don't know what treatment they're getting, the people observing don't know what's treatment the patient's got. At the end of the day, you can sort of like work out if the treatment's truly made a difference. So that's randomised controlled trials are the most scientifically pure tests that we can do. So when you look at all the trials, there is evidence that DBS does help the motor symptoms, and that's been replicated over time. So there was a big meta-analysis of the trials in 2005. And in people that have Parkinson's disease might know their doctors sometimes measure their disease on this scale called the UPDRS, the Unified Parkinson's Disease Rating Scale. And one part of that, the part 3, that measures the motor function. And so back in 2005, if you looked at all the trials, there was an improvement of sort of 55 to 60% in their motor function. And then people in Sydney actually reproduced that meta-analysis with all the new literature that had come through in the 10-year interval, and they found the same results. So there seems to be a lot of evidence that DBS is better than just trying to keep with the tablets once you start to get that deterioration. And in our own group, when we look at our data, it's about a 64% reduction. So I don't think that statistically means because we get 64% we're better than anyone else, but at least we're not worse than anyone else. You don't need to take the tablets as much as, so David was lucky enough to get off his tablets altogether. If you look again at the meta-analyses of the literature, probably between 30, for the overall population, they can reduce their tablets by 30 to 50%. And a lot of people find that tablets do cause side effects and are burdensome to take, so trying to get them down helps. In our own group, again, we get about a 70% reduction in the dopamine tablet requirement, and we get about 25% of our patients off tablets altogether. So again, there's been multiple randomised controlled trials to show that DBS is better than best medical therapy. The early trials were all to do with people with quite advanced Parkinson's disease. I guess it was a bit scary offering this scary brain surgery to people, so we used to wait till people got quite disabled. But there was a very pivotal trial, a European trial that got published in 2013, which looked at DBS earlier on in the condition. So it was looking at younger patients with people for the disease for less time, and it showed that they actually did better. So there's been, since that, last 5 to 6 years, there's been a move to offering people earlier, and maybe David might agree that, if you had your DBS in 2012 or something like that, you might have been able to stay in the workforce and things like that. So just intuitively, you'd think there's more socio-economic benefit to keep younger people with the condition who are at work, keep them in the workforce and not have to take an early retirement. But there's always, the counterbalance to think of. So it's certainly DBS is not a cure for Parkinson's disease. It's not really a cure for anything that we use it for, but it can help give people a better life by controlling the symptoms. It's probably mostly not helpful for a lot of the non-motor symptoms, so it's good. And the literature in this is a bit mixed, and our results are a bit mixed, so it's good that David had some benefit for some of the non-motor symptoms, but he also said some of the non-motor symptoms that didn't really help, so that's what we often find. And certainly there are complications and adverse effects to think of. So some of the potential adverse effects can be directly related to the surgery or the hardware, so we can injure the brain. That's very, very rare, but that's a possibility. We can get infections. David talked about the tethering, the scar tissue that forms around the lid and the neck. Sometimes the wires break or people fall on them. Then they fracture, so there can be some surgical complications. And then for the particular target, we tend to use, because it gets the best result, for Parkinson's disease, the subthalamic nucleus, or the STN, or as David said, you can get speech disturbance, and you can get this sort of like impulsivity and maybe some bit of personality change. And because when we stimulate the STN, it sort of takes the brake off. So Parkinson's is essentially a slow movement, so your movements are too slow. So with DBS, we take the brake off and let the movements come back again. But we can also take the brake off some of these emotional and cognitive and things that make people a bit impulsive. And then reducing the dopamine, that can also, some people become very dependent on the dopamine and it's sort of be masking depression or anxiety. So if we reduce that, some of those other things come back. So it can be very complex, a mixture of the DBS and pre-existing problems and what medication changes happen and the environment. You know, some sounds like David's wife has been pretty good about it all. It's been our experience that some spouses aren't as, I don't know what the right word is, aren't as willing to work with the person for a while after DBS. So even though there can be these problems, and I'll emphasise, if you have the appropriate team, usually you can get on top of those, and then at the end of the day, the person's a winner there. So it just comes back, the DBS is really a team sport, so it's not just certainly not just the surgeon or the neurologist, but there's sort of many people involved. And I think being a surgeon, I see myself as sort of like the manager of a European football club, that what I do is not actually particularly clever or brilliant, but my best skill is just bringing everyone in the team to work together. And even people like the orderlies or the porters that take the patient around the hospital and the radiology techs that do the scans and things, if you get everybody to buy into it, it's sort of just as much better outcome for the patient. So just to reassure some people that might be thinking, oh, this brain surgery is pretty scary, to say that we do approach it in a very kind of organised, informal and hopefully appropriate manner. So when we select people for DBS, or we at least talk to them or offer it to them, so initially the movement disorder neurologist is the best person to assess if this is an option for the person and their family to consider. And then we really have a multidisciplinary assessment, not just of the potential patient, but also their family and carers. And that involves the neuropsychiatrist, we have a rehab physician on our team, we have DBS nurses. We just want to make sure that everyone understands what's going on and the patient and their family have realistic expectations, like we're not going to make them 21 again, we're not going to totally cure this, but and just know that what the potential risks are. During the surgery, so we have as David said, at least with us and most people in Australia, we tend to have the patient awake for a little bit of the operation, so we can sort of do our test electricity, and I'll show you in a second example of that. So if we have a good anaesthetist that can help keep the patient calm, I would hope these days that Ben's not taking 9 hours to do your case, so we typically get through the case in 3 to 3.5 hours from the time we start, and the awake time's typally about sort of 30 minutes or so for that, so it doesn't have to be as scary as people think. Certainly, particularly in the US, there's a move to do these all asleep and just really relying on the imaging. We like to rely on the intraoperative findings as well as the imaging, but there are times and conditions that we do it asleep too. So if the patient's really anxious and really doesn't want to be awake at all, we do little kids with dystonia, people with Tourette's syndrome that are jerking around, so you can't have that happening while you've got things in your brain. So we can do it. We have the capacity to do it asleep if we need to. And then the neurologist, as you saw Professor Silver, he comes into the operating room with me and he helps with the selecting the target and the assessment when we're doing our test stimulation. Then around the time of the surgery, while the patient's still in hospital, while we all have our different roles, I look after the surgery part, the neurologist looks after the stimulation parameters and the medication. The neuropsychiatrist comes just to check for some of those, any early mood disorders. The allied health people help with walking, and the speech therapist is involved. Our rehab physician comes around, and occasionally, depending on the person, they might even have some formal inpatient rehabilitation before they go home. And our ward nursing staff are pretty highly trained. And then once people get out of hospital and have the post-discharge care, probably my role as the surgeon tends to wind down a little bit, but the neurologist is there, our DBS nurses, and they operate a call centre so people can phone up, and neuropsychiatrists, and we have a psychologist there particularly to help with some of these. Generally it's transient and early, but some of these family dynamic changes and things. But I think the key is that if people have problems post-operatively, we just everyone tries to look after them early and not sort of, oh, you'll give you an appointment for 3 months or something there. Part of what we do, I think it's important to be involved in research and education, so we should monitor our outcomes, participate in clinical trials, help with education like sessions like this, and we have sort of fellows that come from overseas to spend time with us, and basically it's fun, like helping people hopefully, but also learning new things about the brain as we go through. So I just wanted to finish just with a couple of examples. So this is like a subgroup of Parkinson's disease where this person had freezing of gait, and it was found it very difficult to start walking. So you can imagine if you lived in an apartment, you're getting the lift up to where you live, and the lift just closes, or you're catching the bus somewhere, or the train, you can't get out before the doors close. So he's just trying to walk, and he just can't, and he can't turn. So this is a sort of a particular subgroup. So there's just trying to turn around that cone, and just can't do it. So you can imagine that would make it difficult to get out of the house. I mean, this was 2 years, so we got him back just because we're part of a research project, but 2 years down the track from his DBS. And so he gets up, he can go. So now he can go into town on the train, he can sort of go up to where he lives. He'll turn around, just comes around. So you can see how just much a difference this can make. This is an example of someone who had essential tremor. So this person literally couldn't feed herself and couldn't dress herself. Her husband had to feed her. And this is just showing what we're doing in surgery with our test electricity. So the person on the right is the anaesthetist, and that's our little highly sophisticated and expensive tremor tester. So we hold that, and we turn the electricity on, and then the tremor just stops. And see, the anaesthetist gets excited, she thinks that's pretty good. And patient, even though they're awake, they're comfortable, they're talking to us. We'll turn the electricity off, and that comes back. So everyone's happy. So we have fun in our operating room, as you can see. So we know, because we've done it awake, we've got that response. We're just going to turn it on again.
And it's still.
So can't feed herself, can feed herself. Like that's pretty, and we know that's our electrode that's in the brain, in the right part of the brain. We're just going to leave it there and just know that it's going to work. So, and this is something that's come up this morning just to finish off. So I've tried to demonstrate that, and I guess everyone will say, as someone else said before, we're biased or whatever. It's like fantastic therapy. But, so we've got 100,000 patients in Australia with Parkinson's disease. Probably 2,000 people have DBS. So that's probably about 15% of people who probably would have been really suitable for it. So why are only 15% of people who would benefit from this therapy not getting it? Well, it's probably multifactorial. So one is that there still seems to be a feeling that this is brave new world, kind of science fiction almost therapy, and it's not really available. It's something they do in America, and it's never come to Australia. But it is available. Every capital city in Australia has more than one unit that can offer this therapy. There's a reluctance of some particularly older neurologists to refer patients for this because, like anybody, once you get a bit older, things that are novel you have trouble sort of processing and coping with. So some neurologists just don't think this is newfangled things that'll never work. And there's we talked about the cost, and then this goes back to that if drugs are kind of inverted commas free, they're on the PBS, or if it gets a PBS listing, it's essentially free, no matter how much it costs the taxpayer. So Dr. Philgood referred to the breast cancer drug, like some breast cancer drugs are many couple of $100,000 a year, but they're free to the patient. Because this is not a drug, it's a treatment, someone has to pay for it, not the taxpayer, or not totally the taxpayer. So patients either in the private system with the patient or the health fund has to pay for it. In the public system, the trouble is that the individual department of surgery has to pay for it. So why do I want to pay $100,000 when I can, we can do 5 hip replacements or something like that. But there's cost benefit to the community down the track. So we've already heard that before with pain stimulation. There's less drug cost. People can stay at work and not be on social security. People have less falls, there's less hospital admissions. People don't get admitted to nursing homes. Just the cost to the community. And there's a lot of evidence. I'm not just making that up. There's evidence-based studies that show that there is cost benefit to the community, but the community doesn't pay for it up front, a patient or a hospital has to. And then you need sort of like skilled teams and people that are happy to work together. Doctors don't always do that. And then because it is a bit of a difficult, there can be early difficulties as we talked about, so you just need to be kind of ready to work with the patients as that goes on. So just to finish that, certainly DBS can transform lives, so hopefully between David and some of the examples you can see that makes a difference, but just to say sometimes it's not as easy as it looks. Certainly there's a potential to cause harm, but I think it's very important that you have high volume and experienced units that do this and people that work in teams so we can assess the patients appropriately and have ready availability to troubleshoot. And I think, like people that work in the area don't squint just to sort of, if you publish and benchmark your results, you can reassure people that it's not actually super scary brain surgery. So thanks.